Yeah, here we go.
Good morning. By introduction, I'm Steve Zeichner. For those of you who don't know me, only my mom has to call me Dr. Zeichner, so if anybody calls me that, I will make it my personal mission to drum you out of the department. Most people just call me Z or Dr. Z. We're going to talk, first of all, good morning. Thanks for getting up today to talk about a topic that's passing interest to most anesthesiologists. That's airway management. Most of what we'll do this morning will be by way of review. You should be familiar with a lot of this stuff, and then this afternoon we'll hopefully have some more fun. So having just completed your internship, that should be a fairly familiar kind of observation or memory. Real quickly, the airway, nasal cavity just warms and filters and humidifies the air. Oral cavity, teeth, tongue, mandible, most common causes of obstruction are going to be there. You've got the palate, roof of the mouth, separates the oropharynx from the naropharynx, posterior soft palate, tonsils, lymph tissues, etc., etc. I'm not going to read all this stuff. Okay. So, what are the components of physical examination of the airway? When you look at somebody, what are the things you do? What's the first thing you do? That's the most famous thing you do. Look at it. What are you looking for?
Normal anatomy, micrographia, and kind of burns, injuries, deviations that you can see tumors.
Body cavities.
Beard.
So, and then we do the most famous thing that we do, which is open mouth. What are we looking for? What do you look for?
How wide they can open, like their jaw mobility, their palate. It's lower.
I don't know the answer to this question, but does anyone know who Mal and Patty was? We'll have to Google it during the day. Another thing to talk about this afternoon. It just struck me now. Why do we do Mal and Patty? How does it help us?
It's very crappily correlated to how bad airway is.
Yes, that's important to know. I can tell you how many Mal and Patty 1s I've struggled with over the years and how many Mal and Patty 4s I go, this is nothing. So it's helpful as a overall thought. I think more than anything else, in patients that you get a poor score with, ahead of time, or you're forewarned that you may have greater difficulty. But it's not a guarantee. Depending on your setting, you should contemplate having extra equipment with you. I practiced for, part of my practice when I was in private practice was in a rural hospital, and I always had the light scope like right outside the door, even for these patients. I never wanted to go running or having somebody go run for it if we had an unexpected difficulty. So look at the mouth and the teeth. Assess range of motion of the neck. Why is that important?
So you can get them in the sniffing position.
Right, because we're trying to line up the axes. Take a look at the submandibular space. So again, when you talk about just generally looking somebody, look at their body habitus. And their ability to slide their mandible forward or prognathate. I love that word. Anybody else like that word? Okay, so here we go. Front view provides an opportunity to get partial and informative assessment of teeth, tongue, hard and soft palate, uvula, as well as tonsils, tonsil arches. Difficulty viewing these, obviously, we talked about, may make it difficult to proceed. What is Mal and Patty? What's class 1? What do we all agree on as class 1?
You have a complete view of the uvula. That's like.
What else?
And the tonsillar pillars.
Yeah. They define. And what if you could see gastric mucosa?
That's bad.
Think of it. What's class 2? Sorry, it's early morning. I'm just trying to keep us all awake. What's class 2? What do you lose? Yeah, you lose that. You lose that, and you still have the hard and soft palate, but the uvula might not be as complete. Class 3.
Soft palate.
I'm old. I can't hear.
You can only see the soft palate, really. You can only see the base of the uvula.
Can you see oropharynx?
No, probably not. A little bit, maybe.
A little bit. Yeah, you might be able to see a little bit. Because in class 4, you lose everything. All you see is really hard palate. So here's just another look at things. Just an additional view from on top, and then sort of a sagittal view. Should be pretty familiar to you. Again, another view. All right. For 5 million points, and possibly the championship of this morning, what is wrong with this picture?
It's upside down.
Good. 5 million points. Keep it in your back pocket. So it's a lot better than a real clinical picture. So pre-oxidation, why do we do it?
Denitrification of morphines.
How much nitrogen is in normal air?
70%.
How much?
78. I don't know.
Yeah, it's almost It's the primary component of the 80% that's left. How about how much? What's the how much nitrogen is in the air at Denver as opposed to Los Angeles?
Still the same percentage, just lower pressure.
Yeah, sorry. Sometimes I'll ask you stuff but it's worth thinking about. So we basically just want to have a greater cushion, a little bit more time, so that in terms of keeping the patient oxygenated. What else is important when we're doing this? What else happens during the period of apnea? Think gas exchange. Carbon dioxide.
Oh, yeah.
And bringing it down a bit prior to that period.
So yeah, I mean, generally you have time. You probably could go, at least 5 to 7 minutes in most people, but you really don't want to. So get into bag mask ventilation. Pretty straightforward, non-invasive. I tell people who, medical students are rotating through, it's the most important skill they're going to learn and you're going to spend a lot of time teaching medical students. I don't care how crappy an intubator somebody is. If they can bag mask ventilate, they can keep somebody alive. Because every now and then, even the best intubator is going to miss somebody. So I'd rather have them be good at that skill, even though the excitement comes from doing that. So we can either do it with one hand or two hand techniques, and I think you guys have all had opportunities to try both of those. Should be getting more comfort, except for pain clinic kind of people.
Yep.
Unless you have a lot of episodes of last. Hopefully that's a negatory. Okay, good. So we've all done both of those. Again, remember you have an unprotected airway, as Jack and Carly and I have learned, albeit at the end of the case instead of the beginning. We can talk about that one this afternoon. Predictors of difficult bag mask ventilation. What you got?
OSA.
No teeth.
Why no teeth?
So everything just kind of folds in on itself.
It's
like an upper airway obstruction.
Right. So it's not so much an acute, it's actually not so much an obstruction, but if you think about it, it's not an acute episode. You get somebody who's, in a boxing match and lost most of his teeth, or, lost the rest of his teeth playing hockey, whatever. If it just happened recently, it's not going to be a big deal. But what happens over time, you get that the bone resorbs without the stimulation of the teeth. So that's what happens. Everything gets sucked in, and you don't have a normal, you don't have a normal face in that sense. So obstructive, as we talked about, age, men, no surprise there. We're a pain in the ass everywhere else. We might as well be a pain in the ass to mask ventilate. Big people, I'm sorry if I have offended your senses with inappropriate humor. I'll try to do better. High Malin-Petty score, beard that was mentioned, and edentulous. So you guys are pretty good. So what other techniques do we have, at least in terms of supraglottic? You can use oral or nasal airways, and you can see functionally why the size is important to sort of line it up with what the appropriate size of the patient is. But with the oral airway, you're trying to sort of get the base of the tongue and sweep that out of the way. The nasal airway just goes down around through it, and they can breathe around. Sometimes waking up, a nasal airway, somebody that's partially obstructing, nasal airway is kind of good to put in ahead of time so that you can make your life a little bit easier. The oral airway sometimes is a little bit more stimulating, and then they'll start bucking and coughing. It's just not pretty. I don't like not pretty. Other supraglottic airways, LMAs, I'm sure most of us, with one rare exception, I won't look at it, but have used these. Have you you've probably worked with primarily iGels. Have you worked with any of the other types?
Classic. I've never heard of an like in here.
Uh-huh. Hey, John.
Hey,
How are you?
not my classroom.
You want to give the rest of this lecture?
No.
Okay.
Thank you, though.
You're welcome.
How are you guys?
Make it your mission to use every single one of these. And again, I guess with the caveat of realizing that not all staff is as excited about doing this as I am. So keep that in the back of your head. But my mission for you guys is to get comfortable with all of them. The AMBU LMA is really good because it's set up almost you can intubate through that if you need to. These are they're elective devices, but they're also emergency airway devices. So and here's just some other supraglottic airways. You won't see most of these in clinical practice anymore, but you have Tulip, the Cobra. Let's see. Again, none of these prevent gastric aspiration, but in a pinch, that's your second concern. Your first concern is at least being able to ventilate them. Now, some of these, like the Rush and the King, do provide some degree of tracheal isolation, but they're really imperfect. You cannot completely blow up a balloon and prevent aspiration. In fact, even an endotracheal tube is not 100%. People can aspirate around an endotracheal tube. And there's the Rush. So, let's talk about endotracheal intubation. Again, the most important thing is positioning our patient to ensure availability. And you got to ensure availability and function of your equipment. Check your laryngoscope. Check your tubes, stylets if you elect to use them. Have you guys had Jack, Carly? Have you been forced to use stylets yet? One time. All right. Sorry to hear that. One of the most overlooked things is suction. That's sort of the first thing I check when I go into the room, even before my machine. It used to be separate, so now it's part of the machine, but I always like to ensure that I have that. Make sure you have oxygen source, depending on where you are. One of the things I like to do first thing in the morning is check the oxygen tanks in the back of the machine. How many of you guys do that as a routine?
Check the pressures on the screen.
Yeah, but you have to open it up. And the reason that's important is if your O2 line goes down, and in institutions like this, it rarely does, but shit happens. So that way you will know, and you will not panic when that happens. You go, okay, just go walk around the machine, crank the thing, we'll be fine. Otherwise, you'll be very nervous for a few seconds until you crank it and make sure that you have pressure. So it's worth doing, and depending, and when you get out of here, you may work at different types of places. I worked in plastic surgeons' offices where their office setup was not as secure. So it was life and death making sure I had those O2 tanks on the machine. So again, we talked about lining up the axes, positioning. You need a straight line of sight from the mouth to the larynx. You want to get that patient in the sniffing position. Cervical flexion aligns the pharyngeal and laryngeal axis. Head extension at the atlanto-occipital joint brings the oral axis closer into alignment with the laryngeal axis. So that way we can achieve the alignment of the oral, pharyngeal, and laryngeal axes. Again, frontal view, lateral view of just opening up the mouth, scissoring, staying on the left. In general, you want to start over to the right and sweep the tongue to the left. We use primarily Mac blades in training, and Mac blades are very forgiving. And looking at different kinds of blades. Here there's the Mac blade, the standard Miller blade, and I think the Wisconsin blade on the bottom. I haven't seen a Wisconsin blade in 30 years, so if I see it, it'll probably be in a museum. But of the other two, they're still commonly in use. And the difference with the Miller or the straight blade is you have to be very fastidious about grabbing that, moving that tongue over. Again, the Mac is very forgiving. If you don't do a great job, it'll let you go. But the Miller blade, if you don't, the tongue is going to be in your way and make your life very difficult. Big difference is where you put the blade and what it does. With both blades, the most important thing is the angle at which you're pulling, and you always want to pull out along the axis of the handle. Always focus on that, pulling up along that axis. Unless you have a brother or sister or cousin that's a dentist, there's not going to be any benefit for you or your family there. And it really won't help you with being able to observe. With the Mac blade, you really getting into the vallecula, and when you pull up, it's just hitting that ligament, and it's counterintuitive, because you wouldn't think it, but it actually pulls that epiglottis up. If you crank back, it actually doesn't work, and the epiglottis still hangs down. You break teeth, and it just doesn't give you the view you want to get. Whereas when you pull up and crank, it'll do the trick. With the Miller blade, and again, not a lot of people use it. I see a lot of people use it. I suspect a lot of people use it the wrong way and put it into the vallecula. The Miller blade is designed to grab the epiglottis and pull it up directly out of the way. Before we had all these fancy video scopes and everything, that was my go-to blade for difficult airways. So Cormac Lahaney, you guys familiar with 1, 2, 3, 4? So I won't spend a lot of time on that. Other things that can help us out are Eschmann endotracheal tube introducers. Have any of you used these? I know some of you guys. If you haven't, make it a mission to use it. Again, talk to your staff. Hopefully they'll be flexible. And my recommendation, when doing it the first time, is intentionally pass it into the esophagus and just feel it go down the esophagus. Then come back out and go down the trachea so that you sense that pop, pop, pop. Because what you'll get is you get the popping off if you go down the esophagus, it's nice and smooth and it'll go down forever. I mean, you can probably, if you have a long enough Eschmann, you can catch it on the other end. But that's not the point here. The point is, though, it's just nice and smooth and nothing's going to stop it. When you get into the trachea, you're going to feel it pop off the tracheal ring, so you'll feel a different sensation. And also, eventually, if you get to the carina, it will naturally want to stop. And then, obviously, video laryngoscopy, and I'm sure we've all had opportunities to look at that. I think that's coming more and more into vogue. If you go into practices of emergency medicine and critical care, they're using that as their first line. I think I'm somewhat, of the opinion. My opinion is I think ultimately we'll give up, being cowboys, even though we're so good at it. We can do these things. I think eventually we'll use these because it just, it's great. What I like about it is that right here, you walk in the room, you've got, one of your colleagues with you, one of me with you, 2 other people hanging around. You got a lot of people who know what you're doing and can help you out. When you're in a room alone with a circulating nurse who doesn't really understand, if you have a video scope, you can look at the scope and say, hey, do me a favor. You see this? Push down here. You see how I push down here and this gets into my view? That's what I want. So they can get feedback about what they're doing and how successful they're doing it. Otherwise, you say push here, push there, and maybe they get it, maybe they don't. So I think one of the advantages if you're working in a room where you don't have somebody else, or you have somebody that's not as well educated, they may not be able to guess what you need. Fiber optic bronchoscopy, has anybody had opportunities to do that yet? Good. And you guys should get, during this first year, not this first month, but during this first year, you should get comfortable doing a sleep fiber optic intubations. Make a point of finding opportunities. Certainly anytime you're working with me, if we have an appropriate day, it's a skill that it's because once you gain that skill, when you have to do it awake, it's easier. Okay, so how do you know you're in the right place? Tell me 6 ways you can be sure you know that endotracheal tube's in the right place.
You saw it go through the cords.
Bingo, number 1.
Auscultation.
Auscultation, 2.
Internal CO2.
3.
Bottom.
4.
Chest rise.
Chest rise, 5. All right, little exercise here. What was that?
You can push on the sternal knob so you can feel it.
And if you can't, doesn't mean. But it's a good idea. All right, we're going to do sort of a little yoga exercise. Close your eyes. All right, reach out with your right hand and imagine squeezing the bag. What does it feel like? There you go. So, all those things. And that resistance, after by this point, after a month, you know that resistance. You know what you're supposed to feel. When you're down esophagus, you will know, it's not right. And I've been fooled because sometimes people will have some CO2 in their stomach, so you'll get a big bump on the CO2 the first breath or two, and then it'll go away. So you can see CO2 sometimes. So rapid sequence, I'm not going to talk much about that today. We all know what it is. So let's just look at some common challenges. People we know and we've seen. Another set of common challenges. These are my favorites. All right, so I may have done a little doctoring with these last 2 slides. Any questions, any thoughts? All right, there's 8 of us, right?
There's more in the afternoon.
Really?
There are more people from the VA come over.
Oh, they will? Okay, cool. How many more people?
3.
All right. So, all right, because it's going to be competitive this afternoon. There will be winners and losers. And there will be prizes. All right, have a great day. Thanks for getting up early. Thanks. Nice meeting those of you guys I haven't yet met. Nice seeing Carly and Jack again. Glad you stayed with us another week.
I did a scene in media video. I thought of you.
Clean eye.
There wasn't blood on the floor.
Yeah. You're changing. You're changing.
Yeah, it's just finally coming to anesthesia.